Hello and welcome to another intensivecarehotline.com and intensivecareathome.com live stream with emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel and I'm your host today. We'll be going for approximately 1 hour. I encourage you to type your questions into the chat pad or join me live on the StreamYard link here, and you can talk to me live on the show. I'll just post the StreamYard link here. Just what makes me qualified to answer your questions that you have for your loved one in intensive care or intensive care at home. Once again, my name is Patrick Hutzel. I'm a critical care nurse by background, and I have been working in critical care for 25 years in 3 different countries, where I worked as a nurse manager in intensive care for over 5 years. And I've been consulting and advocating for families in intensive care here at intensivecarehotline.com since 2013. And I can very confidently say that we have saved many lives for our clients and members in intensive care. And you can verify that on our testimonial section at intensivecarehotline.com. And you can also verify it on our intensivecarehotline.com podcast section, where you can watch or listen to client interviews. I am also the founder and managing director of Intensive Care at Home, and you can find more information at intensivecareathome.com. With Intensive Care at Home, we're sending our critical care nurses into the home to provide a genuine alternative to a long-term stay in intensive care. With Intensive Care at Home, we are currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. We are NDIS approved all around the country, TAC and WorkSafe approved in Victoria, iCare in New South Wales, and NIISQ in Queensland. We're also DVA approved all around the country. And if you're in the US or in the UK watching this and you want help for intensive care at home, I also encourage you to reach out to us. We can help you privately. Now, if you don't have any questions typing into the chat pad, or if you want to, type your questions into the chat pad, or just join me live on the StreamYard link here if you want to talk to me directly. If not, I will just start out with questions that have come in this week, or even in the last few hours. I've got an email here from Diana, who asks, "Hi Patrick, what do you say to the doctor who wants to take you off 2 drugs, dexamethasone and octreotide, which are for a blockage he has, and they assumed he wouldn't make it through the first week? He's at home, and today he's not feeling well, but prior has been okay, and the drugs have allowed him to have bowel movements. Without these drugs, I'm afraid he'll die. They told me he could go to the hospital or palliative care if he gets sick when he wants to stay at home. And that's what they wanted, but it's changed now. I have a phone consultation with the doctor on Monday and need advice on what to say if he decides to take him off the medication." Thank you so much, Diana, for sending that in. And I spoke to you yesterday. And Diana, this is nothing short of outrageous what you are dealing with here from a hospital perspective. Like I said to you yesterday, I wouldn't wait for Monday. I would send an email to hospital executive that they are killing your husband, right? And I would not mince my words here, because that's what it is, right? So the question that you need to ask, whether it's to hospital executives or to the doctor tomorrow, is, what's the hurry to kill your husband? Where's the hurry? Where's the hurry to kill someone? But even worse, now they're asking to get him back to hospital. That's ridiculous. Your husband wants to be at home, and they have to provide the environment to keep your husband at home with the dexamethasone and with the octreotide, right? Because taking that away will kill him, right? So that's one thing you need to say, right? The next thing you need to say, but not only you need to say, you also need to look at, is your rights as a patient and as a family. Now, once again, by taking away medications that keep him alive, that in my mind is at a bare minimum euthanasia. It could also be perceived as murder, right? So I would actually use those terms with a hospital, because this could be a criminal offense, right? So I would frame it that way. But next, I know you're in Canada, but the next question you need to ask is, well, you probably need to research, and we can do some of the work for you there. What are your rights as a patient and a family? I argue that your rights as a patient, as a family, are that they can't make treatment decisions over the head of you and your husband if that's not what he wants, especially if it leads towards him inevitably dying with that decision making, right? So that would be other things that you can do. Another thing that I would urgently do if I was you, I would like you to see getting access to the medical records, right? And I would like you to take those medical records and get a second opinion. Now, we can help you with a second opinion, but it doesn't have to be us. It could be someone else as well, right? Because what you want is to buy time, right? Once again, the biggest question for me here is, where's the hurry to kill your husband? Why are they in such a hurry to kill your husband? And by them asking you to get him back into hospital, to have palliative care or hospice, that is absolutely ludicrous. Unheard of. It is absolutely unheard of. Now, statistics and research has shown that 75% of people or the population in Western countries want to die at home. And yet statistics also say that less than 15% actually do die at home. And then there's no, if they can continue with the dexamethasone and the octreotide, your husband may not die at all. Now, we'll say this as well. In Canada, I know you've got this, from my perspective, this lunatic Justin Trudeau, who's trying to push for euthanasia laws. No wonder that the hospitals are trying to push towards end of life. I don't want to get into politics here, but from all I can see with Justin Trudeau in Canada, he's trying to implement those mad woke policies about euthanasia and all of that. No surprise, you are in a situation like that, or many Canadians even might be in a situation like that, because a life seems to be getting worthless in Canada, right? That's besides my professional opinion. I'm just watching what's happening in Canada, and it concerns me greatly. But those are steps you should be taking. And like I said to you, Diane, on the phone yesterday, we can write you an email to hospital executive, and we've done so many times with much success. I would be breaking this down in even more detail in the written word, right, to write to hospital executive, and we've done so with much success. Also, don't forget, Diane, you have rights. So why am I saying that? Because there's two reasons why I'm saying that. Number one, hospitals are very good to pretend they can do whatever they want. Let me repeat that. Hospitals pretend they can do whatever they want. And that includes end of life. They often say, oh yeah, we'll just do this, and this. We'll take away life support and your loved one will die because it's quote unquote in their best interest. What a joke. Now, the minute you challenge that, they will stop pretending. That's also my experience. The minute you challenge that, they will stop pretending, because you have rights. You just haven't had time to look at your rights, right? So I think you are in a good position to challenge it. I also think you are in a good position to turn this around, but you just got to take the right steps and make some noise, not give up, and don't be scared. Don't be scared. The minute you're scared, they will walk all over you, right? And it is really, it almost looks to me like some hospitals might get even incentivized to move people towards end of life, right? And I think that's particularly concerning at the moment in the US and in Canada, because, you might have heard me say on some other podcasts here that in the US there was a documentary in 2023, September 2023, from CBC, where they've exposed that some hospitals in the US get incentivized by some insurances to move people towards palliative care, hospice, and end of life. They get incentivized for that. They basically get incentivized to kill people, right? You have to let that sink in, right? And like I said, it's a documentary on CBC, and I have linked to it on many of my blog posts here. You will find it if you look at intensivecarehotline.com. If you look at some of my blog posts, I've linked there to the documentary. So I'm not making it up. And it's getting better. In that documentary, they've also exposed that when people are moved to palliative care, hospice, and end-of-life care in those hospitals, those people don't even show up in the mortality rates of the hospitals, making the numbers really look good. Unbelievable. So in Canada, you've got a different health system. You've got more like a communist-style healthcare system, where the government is trying to pull the pull the strings, right, and basically get people off their off their books, so that they stop paying for them in hospitals. But once again, you just need to be aware of the dynamics, and you need to be, standing up for what is right here. Also, Diana, like I said, in your state law, in where you are, in the province that you are in Canada, I'm 100% certain there is like an end-of-life decision-making protocol, an end-of-life decision-making policy, right, where it says something along the lines of, they can't just kill your husband without his or your consent. I would research that if I was you, and like I said, we would do the research for you if you were to become a client, right? So Diana, I hope that helps, right? There would be also something in Canada, or in any country for that matter, there would be also something around, there would be some legislation around freedom of choice of treatment, right? So keep that in mind as well. Okay, so Diane, let me know if you have any other questions there, or if you want to join me live on the StreamYard link here, just click on the link. William, I did get your email, and I will answer your email now. Thanks for joining the live stream. I will read your email out now. Hi Patrick, my name is William. I'm trying to fulfill my mother's last wish to die at home. She's being kept alive by vasopressin, norepinephrine, epinephrine, and CRRT dialysis. This stems from heart failure and sudden heart arrest, you mean cardiac arrest, from an increased milrinone, unknown why to increase, on the day we were speaking of her discharge from the hospital. Wow. She had a sudden cardiac arrest from an increased milrinone dose. Wow. This suddenly stopped her heart. I received a call 2 hours after a conversation discussing her coming home to perform CPR. She was on vasopressin, and then she became stable, and she was put back on the lower original dose. A week later, they found MDRO infection in the lungs. You probably mean MRSA. MDRO might be MDRO, but it's probably more likely MRSA, infection in the lungs. She battled infections for 2 weeks. The hospital thought it cleared up. The next day, her body crashed, and they found another pneumonia. That was a week ago. She's no longer stable, except for high doses of the medications like you mentioned in the earlier part of your email, and her acid levels rise quickly off the CRRT dialysis. Yeah, no surprises there. Today, her acid levels reached high enough levels to introduce bicarb to lower. Yeah, okay. She's scared of dying. This was all very quick. She just wants to be at home when she passes. The problem is hospice will remove all medications and machines, and you put in quotes, comfort her. I'm looking for a way to have a CRT and highly trained personnel set up this in our home. I've heard of this, but no one has helped me out with this yet. Wasted a lot of time. Is this possible to get her home with the meds, equipment, and staff to run? They consider it curative therapy, even though I'm trying to bring her home with awareness of her being there. Please give me some ideas or suggestions. All is appreciated. Thank you so much, from William. Okay. So, William, you are alluding to that you and I have spoken. I can't remember that, but that doesn't mean that we haven't spoken. I'm getting so many phone calls, but I think you are alluding in your email that you and I might have spoken on the phone at some point. I can't remember, but anyway. So, William, I'm not sure how much research you've done. You might have done some research with intensive care at home. We are running an organisation, Intensive Care at Home, in Australia, right? I'm in Melbourne, Australia. And we are sending our critical care nurses into the home for mainly long-term ventilation and tracheostomy, right? But also for home BiPAP, home CPAP, home TPN, home IV potassium infusion, home IV magnesium infusion, central line management, PICC line management, Hickman's line management, as well as Portacath management. So, with all of that said, we have also provided care to similar type of clients than what you are describing, how you're describing your mother's situation. Is it possible? Absolutely is. Now, I don't know your location. Can you share with me where you're located? Are you in the US? Are you in the UK? Are you in Australia? If you are in Australia, I believe we can absolutely help you. If you are in the US, we can probably also help you, but it wouldn't be us directly. It would probably be more on a consultative role. William, can you share your location so I can, in Houston, Texas? Okay. So, I'm not aware of any provider similar to what we do here in Australia. And the reason I know that is I have done some research. We are thinking of entering the US market, but we're not there yet. And I've done a lot of research in recent years. There are no providers in the US as far as I'm concerned, let alone in Houston. Now, that doesn't mean it's not possible. Doesn't mean there is no provider that necessarily can pull this off, but they might need to pull it off under guidance, right? And under guidance, I mean, we could guide them, right? We could absolutely guide them because we've done this type of work here in Australia. Now, the challenge in a situation like that, William, is this needs to happen quickly. If your mum is on vasopressors that are probably getting more and more maxed out, and she is on CRRT, and she's becoming acidotic, right? Those are all not good signs, which means you don't have a lot of time to make this happen, right? They only release her to ICU doctor or hospice. Yeah, you will need an ICU doctor to oversee it. But what you also need is, you need an ICU doctor to oversee the care at home, but you also need a team of critical care nurses providing the actual care at home. A doctor will not provide the care. The doctor will just oversee the care, and the doctor will pull the strings, what medications are needed, how do we communicate to the nurses. Your bigger challenge here is to mobilize also a nursing workforce that can pull this off, right? And like I said, some provider might be able to do it, but do providers have critical care nurses on their books in the community? Most likely not. That's the entirety of the innovation that's coming into the community, that critical care nurses are deployed into the community. And that's innovative and new in and of itself, right? So how can you pull this off? You can pull it off by finding a provider in your area that is a community nursing service that either has critical care nurses on their books, which I doubt they do, or who is happy to hire them. They need to hire them at the drop of a hat, and then they need to be trained, or they need to be guided in a home care environment. As much as we are bringing intensive care into the home, providing this level of care in the home is a different ball game. You don't want, as much as you want your mom at home, and I totally get it. Like, I've been in the home care, in the intensive care home business for a long time now. I totally get it, right? But it has to be safe. It has to meet the needs of what your mother wants, right? And part of that need can only be met if you've got the right people coming into your home. And they have to be the right people. But it can be pulled off. The question that I have for you is, how much time do you have? And I'll tell you what concerns me, William. If your mum is becoming acidotic, they're now starting to use bicarbonate. That's often the beginning, that things are not looking good, that the organs are shutting down, right? I would also ask for her lactate level if I was you, right? If her lactate level is increasing, you will even have less time. One of the signs of a patient dying in ICU is when vasopressors keep going up, there's dialysis going, or CRT, right? And there's multiple inotropes going in and so forth, right? They become acidotic, patients become acidotic, and then eventually they have their lactate rise, right? And once lactate is rising, it's going to be more and more and increasingly more difficult to turn the situation around. But I would ask what your mom's lactate level is. I think this is critically important for this situation, right? So I hope, what needs to happen in a situation like that, William? Obviously, the equipment needs to be organized. That's one thing that needs to happen. I will be back in camera in a second. Equipment needs to be organized, right? What also needs to be organized is the staff, of course, right? I assume your house where you want to take your mother to is big enough. I would imagine, your house is big enough. The setup is big enough. But, it might also be a reasonably quick situation where your mom might go home, maybe even only for a few hours. And if that is the case, the setup doesn't have to be perfect. It can be very imperfect, and that's going to be okay. I can fully understand that your mom's wish is to die at home. I can totally get that. I've been writing about this for years. I've been making videos about it for years. I totally understand the need for what you and your mom want here in this situation. So what's a high number? I presume you are referring to lactate. I would say a high number for lactate that sort of is worrying, sort of 3 to 4, but also with a trend of rising. It's probably more to watch the trend, right? It's probably more that. The other issue that comes out of this, William, is when they take her off dialysis, to change the filter, or, if they take her off dialysis to maybe flush the line, whatever the case may be, and she's getting acidotic pretty quickly once again, that unfortunately is not a good sign, right? And the question is, how big is her tolerance also for transport here? So what do I mean by that? I'm the first one to say that critically ill patients can be transferred. They can be transferred from one ICU to another. whether that's via road ambulance, whether that's via air ambulance. I'm the first one to say this is possible, right? I've seen many critically ill patients being flown around, driven around. It is absolutely possible with the right resources in place, with the right teams in place. Now, if your mum is on multiple inotropes or vasopressors, and she's on CRRT, they would need to disconnect or discontinue the CRRT at least for a while. And if they need to do that, she's becoming acidotic again, right? And that is a risk. And whilst she's remaining on high doses of vasopressors, is she really safe to be transferred home, right? Is she going to survive a transfer home? That's really where I'm wanting to go with this. William, how far away is your mum's home from the hospital? What are we talking about here in terms of, is it 10 minutes down the road? Is it 2 hours down the road? What are we talking about here in terms of logistics? Right? Then the other challenge here, William, is 1 hour drive. Okay. The other challenge here is this, William. So let's just say you would be in Australia hypothetically, and you would be in Melbourne or in Sydney, and we would pull this off for you. I would know which one of our nurses would be the right fit. Once you and I would have spoken in more detail, I would have an inkling of, okay, who would be the right staff member or staff members to go to William, right? Now, you're starting with this from scratch and you don't have a lot of time, right? So you need a critical care nurse, or you need critical care nurses here, but you also need critical care nurses that can work in someone's home. And I'm not suggesting that's a rare breed, that those people exist and they're out there, right? But you have to select the right people in a short period of time, right? She can handle a 3-hour break yesterday of a CRT to clean the lines. Okay, yeah, that's good. Well, that should give you enough time to take her home. My question though is, when you take her off CRT, is her blood pressure dropping or is it increasing? Do you know? If her blood pressure is dropping or increasing while she's off CRT, right? Also, what would be interesting and probably also important to know is, what are her potassium levels, right? Do you know her potassium levels? And the reason I'm asking for potassium levels, if you take someone in renal failure or in kidney failure off CRRT, potassium might creep up pretty quickly. And then again, your mum would be at risk of cardiac arrest, right? Would be at risk of cardiac arrest. But William, I totally get where you're coming from. Potassium levels are up and down, yeah, and they'll be up and down depending on whether she's on CRRT or off CRRT. They will come down when she's on CRRT. They will go up if they discontinue the CRRT. She has a pacemaker too. Yeah, that's not necessarily a bad thing that she's got a pacemaker. Probably a good thing here. Yeah, William, it's all possible, but you can see that the logistics around it are not straightforward, right? And I'm not, I don't think I'm the person that's trying to overcomplicate. I'm running my business very solution oriented, because that's what we need to do. We need to find solutions all day, every day, right? So my advice here, William, is to contact some home care nursing agencies in Houston and share your scenario with them, and see whether there's A, appetite, and B, do they think they can pull it off under guidance, right? The other question here, William, is how much time, how much time do you think she has? And I know that's a very difficult question to answer because no one has a crystal ball. What are they telling you how much time she has in terms of, life expectancy, or are they potentially even thinking that it can be turned around? Or are they telling you this is, what I would refer to a real end of life situation? Is it a real end of life situation? Is it a perceived end of life situation? Do you have any idea there in terms of timelines? No life expectancy after I remove anything. Yeah, no, I get that. I totally get that. I totally get that. That she's on too much support, that you could not take anything away. But what I'm wondering is the treatment that she's getting at the moment, is that potentially leading to reversing her condition? Or do they think that the ongoing treatment is just to maintain the status quo, but will inevitably lead to end of life? That's more what I'm asking here. Do they think it's reversible? They say it could range from minutes to hours. Yeah. I would argue that if you take her off the CRT and you take her off the inotropes and the vasopressors and you take her off ventilation, I would suggest it's only going to be minutes. Yeah, okay. Do you know what ventilation support she's on? Do you know how much ventilation support she's on? Do you know her FiO2, like how much oxygen she's on from the ventilator? Do you know that? I don't think that's part of your email, because that would also be important to know. Just give me 1 second. She only has BiPAP. She's not intubated. She doesn't have a breathing tube in her mouth. She doesn't have a breathing tube. Right. Okay. Right. That's interesting. So your mum is conscious. Is your mother conscious? No, she's fully conscious and aware for part of the day. Okay. Okay. That's interesting. Well, the good news is she can vocalize herself what she wants. That's a good thing. If she's awake, that also means she's on no sedation. That's good. I would be curious to know how much vasopressin, noradrenaline, epinephrine she's on. Do you know how much she's on? That is why this is so hard. She says she's so scared. Yeah. Yeah, I can see that. That's on the one hand, it's incredibly difficult, of course. On the other hand, if she's not fully ventilator dependent, if she's on the BiPAP on and off, that's actually a good thing, because I was under the impression she's fully ventilator dependent. She's in an induced coma. She's ventilated with a breathing tube or with a tracheostomy. So that's actually not a bad thing, because that means she's actually on less support than I thought she was. That also makes the transport back home more likely, because she's not fully ventilator dependent. I left the hospitals for this. They said it's a high level levo, mid-range of epinephrine. Okay. So that then, I would say, is making a transfer home much more likely. Much more likely. So that's actually a good thing. That is actually a good thing. Now, William, I need to go back to your email. So your mom had a cardiac arrest. Is there supposedly any brain damage? We're speaking from, just going back to your email. Sudden cardiac arrest. How long did they do CPR for? A few more questions here, William. How long did they do CPR for? That's one question. The other question is, when did all of this happen? How long ago was the cardiac arrest? That would also be important to know. How many days are we talking about here? In your email, you're also saying they consider it curative therapy, even though I'm trying to bring on with awareness of her being there. You know, the more we talk about it and the deeper we dig here, you know, I think there's also a chance that your mom might recover from this, right? You haven't been told, but she doesn't seem like she has heavy hypoxic damage. Yeah, okay. Well, the other thing you should be doing, William, is you should be getting access to the medical records here. Right? You should be getting access to the medical records here. The other thing, yes, how many days ago did all of this happen? Temperature seemed to have like she's heavy. How many days ago did all of this happen? That's one question. The other question is, was your mum intubated at some point? And if she was intubated, when did they extubate her? This has been 5 days. Not a long time. Not a long time. So, okay. So, 5 days. Was she ever intubated? Do you know if she was ever intubated? You just tell me yes or no. William, has your mom ever been intubated? Maybe you don't know what intubation means. Intubation means she was intubated 3 weeks ago when she had the cardiac arrest. Hang on, now I'm confused. So the cardiac arrest was 3 weeks ago, but then you're saying it's been 5 days. William, do you want to jump on the call here? Because I think we can nut it out much quicker if you want to jump on the call here. Talk to me directly. You don't have to go on camera if you don't want to, but I think we can get to what you're trying to achieve much quicker if you jump on the call with me here. It's up to you, of course. They took her off a day later. Okay, she was intubated. They took her off a day later. Okay, that's really good. That's really good. Is she having a sepsis? Do you know if she's having an infection? Right, that would also be important to know. Is she having an infection? What else is she potentially battling? Other question. Is there a cardiologist involved? Right? Is there a cardiologist involved? That would be one important question. And with the cardiac arrest, did she have an angiogram, like a screening of the heart with a heart catheter? Did she have that? And next, William, there you are. That is so good. Yeah, that is so good. Hang on. Can you hear me, William?
Yes, I can. Can you hear me?
I can hear you. Thank you so much for coming on.
Okay,
I can hear
good.
you. I can hear you. Thank you so much
Okay, great.
for coming on to the call. William, is there a cardiologist involved in all of this?
She's a heart patient, so there's a team of cardiologists working on everything.
Okay. Has she had an angiogram? Do you know what I mean by that?
What is that? No.
Did she have a screening of her heart after the cardiac arrest
Okay, well, she's I don't know.
Don't know.
They don't know. Yeah, I'm just assuming they did. They did all the tests they were supposedly to do, and then they've been taking X-rays, of course, of her chest and everything every day. So
Right. Okay. Okay. So is the hospital open to take her home? Are they open to the idea?
they say they want to only transfer her to ICU and hospice. When I brought this subject up, they were starting to freak out.
They're
Right.
starting to freak out.
Yeah.
Okay. But William, now that you're telling me your mother is awake,
Mm-hmm.
I am, do they need to stop talking about end of life, and do they just need to get on with treatment and hopefully turn this situation around? Because it sounds to me like that's a possibility too.
What's this? What they're saying, since the vasopressors and all keep rising, and they have that she's getting to the at max level, that it's impossible for it to be turned around.
Okay. What's the main issue there? Is it heart failure? Or
Yeah,
is it
she's had multiple, yes, it's heart failure and COPD, lung disease. So she was denied for transplants and all those. So all the major hospitals, we've been attempting to, and the problem also with that, she was full of pneumonia the first time they asked for to get her baseline, right? So everybody said no.
how old is your mom?
67.
Not very old.
Mm-mm.
Do you know, have you heard of the term ejection fraction?
Injection fraction. No, I have not.
Okay. I would be very, very curious what your mom's ejection fraction is. Basically, ejection fraction is a percentage that the doctors will get from an ultrasound of the heart, how strong a heart is pumping.
Okay.
And that would be a very good indicator in terms of where this is going. If her ejection fraction is poor, chances of survival are lower.
Okay.
If her ejection fraction is, I'd say, 35 and above, maybe this can be turned around,
Okay.
right? Does your mom have a history of cardiomyopathy?
That's the irregular heartbeat?
No, that
No,
would be no.
that would be
That
arrhythmia. Yeah.
that would be like atrial fibrillation or AFib.
Okay.
Have you heard of that?
She received. Okay, so the reason she had her she received the pacemaker a few months ago because her cardiologist, she was born with TOS. All right, and so she's had a surgery on her heart to close the hole back when she was 7. She repeated this process 30 years ago. The cardiologist she was seeing has found leaky valves, so he put them the mitral clip in there and has cauterized a couple of areas to try and get it to stop. Every time he's done these new things, she's gotten weaker and weaker and weaker. Hence, they ended up putting in the pacemaker due to a heart arrhythmia a couple of times, and so that was all cleared up. But when they um, when her heart arrested, all right, when they raised the milrinone about 3 weeks ago, her heart arrested and the pacemaker wasn't complete. They didn't have the second coil on the bottom, so it didn't fire and it didn't work. Okay, they again they called me to have perform CPR. It took them about 15 minutes for that conversation, but then she was intubated for about 24 hours when they were there to pull it off. Okay, then it was back on these same things, the epinephrine, the vasopressors for the next couple of days. They took her off of it, put her back on a milrinone, back to the lower dose, and she was okay. Now she got a pneumonia, and so they were taking care of that. Then they called it, yeah, it was an MDRO, multi-drug resistant organism in her lungs. They continued with meropenem,
Meropenem.
yes, meropenem and vancomycin together, and they've done her a couple a couple, what do you call it? A couple rounds of the vancomycin. They would check her, of course, to see if her white blood cell count and everything. Well, they take her off, and then about 5 days ago, she got real tired, real everything. They pulled all the blood panels. They found another pneumonia, and that's the same day everything went down so far. They say her body just crashed, and that's when she had to go back on the CRT. But when they put her all back on the epinephrine, on the norepinephrine, and everything else, it was all one day again. Just all one day.
Okay, William, do you have access to the medical records?
I do, and not on me, not this moment. Yes.
Right. I would be very, very curious. I'm almost 99% certain they would have done an ultrasound of the heart at some point.
Yeah.
And with that ultrasound of the heart, they would have done what's called an ejection fraction. I think I would be really curious to know what they determine is her ejection fraction.
Okay.
I believe a lot of your answers, what to do next, lie there somewhere.
All right.
Right? Because it really depends on how weak the heart is. Now, with the infection in the lungs, are they saying that's cured?
They don't see another infection in the lungs, but the cardiologist that came in this morning said there must be some infection in her body to start another vancomycin run. So
there must be what?
There must be some type of infection because they need to starting another round of vancomycin.
I see. Which is probably also contributing to them or to her needing more vasopressors.
Yeah.
Do you know if she's got a temperature? If she's got
no, her temperature always stays low. She's almost hypothermic. We keep her heated up. So
because of the CRT. Of the CRT.
Okay.
Her temperature would be masked because of the CRT. The minute they take her off the CRT, her temperature would go up. The question is, how high would the temperature go?
Okay.
Do you know her white cell count number?
Not of today, no. I mean, she just said it has to be high, so it must be an infection. That was the cardiologist. So. But no, I didn't get a specific number.
Right. Okay. Right. So, look, William, what I'm trying to find out here is, if your mom was to go home for end of life and that's her wish, then you probably have to keep getting the wheels in motion for that.
Right.
But what I'm wondering is she potentially better off to stay in hospital for now, because there is a chance of a turnaround? Now, I know they're telling you there's not.
That's right. They're telling me.
But it's your mom is awake.
Right. That's what I keep saying to them. I mean,
your mom is awake. Your mom is alive. Your mom is awake and your mom is alive. Right?
Mm-hmm.
A patient who's dying, generally speaking, is not awake. Generally speaking. No, there's always exceptions to the rule. And I'm not dismissing that your mom is on high levels of vasopressors.
Right.
Take that away, your mom would probably die. But
right.
I'm wondering, are these all temporary measures to get her to improve? Because if that was the case, then I do believe your mom would be better off to stay in hospital and stay put.
Got you. I see what you're saying.
Right. When I first read your email, I read she's intubated, she's not talking, I assumed that, but that's obviously a different scenario. And how often is she on BiPAP in a day? How often?
She'll literally ask for it. Her oxygen levels stay at 100, and then it depends on what alert she is, whether they'll look for the gas test, right? And then they'll take it, and then usually she'll last 4 hours on it, and then take it off. Last day or so, she wear it for about 8 hours. But when she chose to, they didn't take her off, and her levels were fine. And they keep saying every morning when she's wearing it overnight, her levels are fine. So,
Do you know, William, how much BiPAP she's getting?
I, if I could see the machine, 20 and 40 and something over something.
20 and 4, probably 20 over 14.
Okay.
Probably.
Okay.
Do you know oxygen levels, like that she's getting from the ventilator?
I think it was 10 liters at the moment. She was on 4, right, until this happened. But now they're up at 10. I mean, they keep everything kind of, they haven't really changed any of those. They're just kind of keeping everything at that level.
Okay. When she's off the ventilator, she's on oxygen.
Yes. Cannula. Yeah.
Cannula. Yeah. Okay. How is your mom getting nutrition?
Since this is a feeding, since 5 days ago, feeding tube through her nose.
Okay. And now?
That's still how they're doing it. Even they'll put the mask on over it, right? And that's still, yeah.
Okay.
Because that pneumonia they found was, they said it's in the lower bottom of her lung, that it has to be from aspiration, and that's, it could have been because I kept telling them that she doesn't need a drink while she's half asleep, and some of these nurses, here you go, and because my mom will just ask for water, ask for ice, ask for anything is anytime she wakes up. So yeah, I mean,
okay. Is your mom getting anything for the anxiety that she's feeling?
Yeah, she gets Ativan.
Ativan.
Yeah, and when she gets put on the mask a lot.
Yeah.
So she has a bed sore up her back and butt, and so she asked for a morphine this afternoon. That's kind of when I saw you and everything, and I said, "Oh my God, let me go check this out." So that's
right. William, what I'm trying to find, it's kind of, I think you're stuck between a rock and a hard place here. Yeah. Your mom might be able to turn this around, and I do believe a lot of it depends on the strength / weakness of her heart.
Okay.
Right. If her heart is weak,
yes,
another medication they could try is a drug called levosimendan. I'll just type that into the chat, Pat, that you can read it there. Levosimendan, I've just typed it in there. That is another drug. It's sort of an inotrope, kind of similar to dobutamine or milrinone, but it's unlike dobutamine or milrinone that run consistently or continuously. Okay. The levosimendan, you just get one dose over a couple of hours, and it's meant to increase the contractility of the heart.
Okay, right. Yeah, I know there's a tag that says Levo, right? And
okay.
They did say that the same thing. Yeah, I didn't think so. That's like the same as the norepinephrine, right?
That's right.
Okay.
The Levo they are referring to here is Levofed.
Okay.
Levosimendan is different.
Okay.
Different.
I'm trying to see.
Like I said, if your mom was ventilated in an induced coma, she was unconscious, I'd say, look, take her home potentially. But to me, it sounds like she's not there yet.
Right. That's the way I see it. Yeah.
Right.
Yeah.
And I do believe that at the moment, I can understand her anxiety. I get it. She's witnessing, this firsthand, which on the one hand, it's good that she's awake. On the other hand, it would be terrifying, of course.
Yeah, and it is. It
would be absolutely terrifying. So,
I mean, that's kind of, that was her words, this hospital's trying to kill me. And I mean, it started with the milrinone, and now she's deathly afraid of being up there by herself. I've been staying with her every day. So, I mean, this is insane. I mean, the nurses are great. They're doing what they're told, and so they're great to her. But I just don't understand half of these, why simple things can't get done. To me, it's simple. I don't know.
Yeah. Look, it's your mom is probably, if you take a scale from 0 to 10,
okay,
for a patient in intensive care, 0 meaning, someone is on their way out of intensive care because they've recovered, or taking a scale of 10 where someone is sort of the highest critical level, right. Your mom is probably at a 9 or a 9.5.
Right. Right.
right?
Right.
But can she pull through this? Can she reverse whatever needs to be reversed?
Mm,
I couldn't tell you because I would need to look at the medical records or talk to doctors and nurses directly.
right.
Then I could probably, it would be way easier for me to recommend the next steps here.
Yeah.
Would be really advantageous to look at the medical records.
Right. 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 Yeah, I can do. Yeah, I could possibly. Yeah, I can actually have somebody.
That would be really advantageous, because whilst I understand and support the need for your mum to go home,
Right.
it may not be the right thing right now. It may not.
Okay. Okay.
Because just because they're telling you they can't turn it around, doesn't mean that they won't.
Okay.
Right? The hospitals will always err on the side of caution. They will always be negative by default.
Okay.
And the reason they will be negative by default is it's easier for them to keep staying with that negative end of life and doom and gloom narrative,
Mm-hmm.
right?
Right.
To if they told you, oh, William, we do this, and this, and it takes us 3 weeks, and then your mum has recovered,
Right.
and it doesn't happen, they could be liable.
Okay.
By them creating this sort of doom and gloom and end of life narrative, if she's not improving, they can always say, well, we told you so.
Right.
You have to read between the lines.
Right.
Everything that they're saying is often to manage their liability.
Yeah. Right. I get that.
Right?
Yep, I get that.
So you have to watch what your mom is actually responding to, and if she's responding to treatment. That's probably the more important question here. It's not so much what they're saying.
Right.
Is your mom responding to treatment?
Okay. I do. I mean, he almost too much, right? I asked the nurse this morning. I said, "Are you making any tests? Are you testing these medicines if you can come down?" He said he went 0.1 down on the levo, the one that's labeled levo, and her blood pressure dropped with it.
Okay. Yeah, that's certainly not a good sign.
Okay.
That's certainly not a good sign. By the same token, there's plenty of patients in ICU where you need to go up and down with the levo all the time,
right?
And yet people may come out of it. It's
Oh.
not.
Okay.
It's fairly unpredictable. What
Okay.
really makes me hopeful here is your mom is alive and she's not fully ventilator dependent.
That's right. Right.
Right. That's to me, that's almost like the most important aspect of this.
Okay.
Right. But I would need to see the other aspects too.
Okay. Yeah.
In terms of particularly her heart function would be of, I do believe a lot of the answers that you're seeking for are in her heart function. What does that look like? If we could quantify that with numbers,
yeah,
that would help.
Okay.
That would help.
Okay.
William, I do need to wrap this up in a second.
Okay.
I hope I've given you some things to think about, and if we can help you with reviewing of medical records and advise you from there, I think that would be a really valuable step for you as a next step.
Okay, and where do I reach that on for you? Just back on the website? And
just keep emailing me. Keep emailing me.
Okay.
Yeah. Okay, I got to wrap this up now.
Thank you so much.
Thank you so much. All the best. Thank you. All right. Now I got to wrap this up now. I said we usually go for an hour. If you like my videos, give the video a like and subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. Click the like button, click the notification bell. Comment below what you think about today's topics and share the video with your friends and families. I do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp at intensivecarehotline.com. And we also have a membership for families of critically ill patients in intensive care where you can become a member. And if you want intensive care at home, go and check out intensivecareathome.com. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com and intensivecarehotline.com, and I will talk to you in a few days. Take care for now.